All right, guys. Well, I appreciate you attending for this one of our first talks of the year, talking about how we can really provide better care to our community and prevent some of these injuries beforehand. Looks like Dr. Davis is just getting on. Both of us are really excited to share with you some insight and education so we can prevent injuries and hopefully treat injuries for our community. I'm Dr. Marc Gruner. I'm a sports physician that is part of Aligned Orthopedic Partners, which is made up of Ortho Bethesda, Shady Grove Orthopedics, Washington Orthopedic Sports Medicine, and Jordan Young Orthopedics. And Dr. Davis is one of our orthopedic sports surgeons, and we look forward to talking with you guys today. Chuck, can you see my slides? And you might have to unmute Dr. Davis at some point, but I'll get started.
I can see your slides. And Dr. Davis, if you could repeat what you were saying a moment ago.
There you go. Now I am unmuted. Hello, guys, and thanks everyone for coming to the talk. Obviously, couple of technical difficulties there, but I think we got things sorted out.
Great. So the goal today is we're going to talk about how we can unlock the secrets to performance and injury prevention in the weekend warrior and the aging athlete. I'm a sports medicine physician. I trained at Mayo Clinic in Rochester, Minnesota, did my medical degree and MBA down at Virginia Tech, and then did residency at Georgetown, followed by my sports fellowship at Mayo Clinic. I've worked with CMS on participating in value-based care in orthopedics, have an interest in regenerative medicine, and do a lot of diagnostic ultrasound, which enables me to do some minimally invasive procedures. And then Dr. Davis is from Cornell University, and he went to my rival, UVA, so I don't hold that against him too much. He completed his orthopedic surgical residency at Indiana University, and then he went on and did a fellowship at Georgetown in sports medicine for arthroscopic meniscal knee surgery, and is a fellow of the American Academy of Orthopedic Surgeons. And then our third doctor is coming in from last night while I was preparing for these slides, and she was really excited to share her doctor outfit.
I'm the doctor. You're the doctor like Daddy. What do you think? You're a doctor. Dr. Ia.
So we really try to start young, educating our community here. And as she came in, I thought it might be good to have this video for today. I do have two conflicts of interest. I'm a co-founder of Limber Health, which provides remote monitoring for patients for therapy, and an AI orthopedic company called Tempeda, which helps with doctors spending more time with patients, but no conflict for this talk. So our agenda today is to review prevention strategies for pickleball season. The spring and summer is coming, and pickleball has grown tremendously in the community where I grew up in Bethesda, Maryland. And there's been a lot of injuries here, so we thought to educate the public would be a really good opportunity to hopefully avoid unnecessary injuries and procedures. Then we'll go over a management of arthritis, followed by a regenerative medicine update, and then we'll focus on surgical treatments of pickleball, which will be led by Dr. Davis. So pickleball. The sport has grown in the last 5 years. 36.5 million people are playing pickleball in the United States, and the growth has been substantial, over 158% growth just in the last 3 years alone. And with that, we see, especially in the Bethesda, Maryland area, there's a huge love for pickleball. In fact, I was looking at some of the statistics, and 98% of married couples who play pickleball end up needing marriage counseling. So people are so in love with pickleball that it's ruining relationships. So really, with this craze of love for pickleball, we realize that there needs to be some changes to how we think about pickleball and how we manage pickleball from an orthopedic perspective. And because there's been such a huge craze in pickleball, we've seen that there's a huge incidence of injuries and cost of care. So this was an article to the left by CNN that talked about how there's over $400 million of extra injuries that happen just because of pickleball in the United States. And the injuries have really substantially increased over the last several years, I think, to the rise in the sport, but also to the type of injuries that people are having from just really enjoying the sport. And as we break it down by age, we see that the sport is not just in the younger population, it's really in more the geriatric, weekend warrior, older population that are really having a lot of fun playing this game. And we see the ages between 60 and 80 that the incidence of injuries are really climbing. And a lot of these are due to acute and chronic injuries, and we'll take a deeper dive into that in the next slide. So this was a study done in 2021 that looked at pickleball injuries by body part, and we saw that one of the highest incidence of injuries was the wrist. So if we're trying to protect the body, the wrist might be one of the first areas to go, and that's because a lot of people fall and they brace with their arm. And wrist injuries followed by lower leg injuries. And most of these are either due to falls or overuse injuries. And as we take a deeper dive into the frequency, we see that that slip, fall, and dive is the most common injury. And then in men, strains and sprains and tears are more common in men, while falls and fractures are more common in women. So to prevent an injury from happening and from seeing me or Dr. Davis in the clinic, we really wanted to highlight some of the common areas of injury by body part and some good preventive strategies to manage it. The first, we'll start off with the ankle. So the ankle, the most common chronic injuries are an ankle fracture, ankle sprain, followed by plantar fasciitis. And plantar fasciitis is the most common injury, and that also happens to be with Achilles tendonitis, and that's because the gastroc muscle can get tight. You can have, if you don't warm up and stretch it out, the quick sudden changes in direction can cause you to get some Achilles tendonitis, which is behind the heel, or plantar fasciitis on the bottom of the heel. So we really recommend wearing some really good running shoes, heel cups, making sure that you have pliable muscles, so trying to stretch and really stretch out your calves specifically. But those are just some helpful tips for ankle injuries. For knee injuries, one of the things that I see a lot is that because the ball is slower than a tennis ball, and it doesn't bounce as high, we really see that those knee injuries, when there's rapid movements either to the side or backwards, can cause someone to have a meniscus injury or an ACL injury. So I think the idea is warming up, trying to identify ways to warm up in like a zigzag pattern, and then really being on your toes as opposed to your heels, especially if you're going backwards. The next thing that we see are hamstring injuries, and this happens similar to what we were talking about for the ankle injuries, where people are going too fast or too slow and suddenly, and it causes this eccentric contraction where the muscle lengthens, and there they can cause a rupture of their quad muscle. They can injure their tendons, and so I think warming up is again really, really, really important there. And because the ball bounces so low, really bending down with your knees and not with your back is a really good way to prevent any unnecessary back injuries. So for the next one, we want to talk about the elbow. So one of the most common injuries for the elbow is tennis elbow, which is an overuse of the tendon at the elbow and can cause pain here. And it's due to the tendons in the wrist, which move your arm, can just get overused. So if you do have pain there, we recommend wearing a brace 2 centimeters below where it hurts, just right here on the elbow. And then we also talk about the way you hold the paddle, and we'll follow up more information in a subsequent slide. For shoulder injuries, we really want to avoid overhead returns as possible. And then for falls, one of the things I mentioned earlier, but avoid running backwards on your heels and try to be on your toes and trying to really not dive for a loose ball. I think people are so excited about the sport, as you can see, that they might dive for a loose ball. And I think that is how we get a unnecessary fracture. So I broke up some prevention strategies into the court, equipment, and how to hold the racket. So for the court, I just want to go over some things for everyone to know. So there's the kitchen right here. And one of the things that we see with the kitchen is that when people are leaning over, and if you lean over too much in a flex posture, and then you rapidly go from flexion to extension, you can injure the disc in your lower back. And so although you want to be very close in the kitchen as much as possible, try not to be too close and try to have a more neutral posture, I think is one thing that we've seen that to be really helpful. The second is being in the ready position. So really trying to be in a neutral position. So when the ball quickly comes to the left or to the right, you can move quickly to one direction so you can be in that ready mid-stance position. The third thing that I already mentioned was just, but when the ball goes into the backcourt, it's really important to, as you're back pedaling, to stay on your toes and not your heels. So from there, we'll get into some hitting tips. There's just some common tips that any ball sport that everyone should know about. The first thing that you should know about is that you want to contact the ball in front of your body. You don't want to be behind your body. We already talked about the back pedaling. The next thing that we really want to talk about is, in the event of a fall, learning to fall gracefully is a really important thing. And so we say going with it means that you're really embracing the fall, and you learn to roll as you fall, as opposed to having your arm extended and being in a extended posture and landing with your wrist, because the most common injury is a wrist fracture. The last thing is for any put away shots, trying to avoid really slamming the ball overhead, I think is one way to injure your rotator cuff. So if we could prevent those overhead shots as much, that would be really helpful. The next thing we'll follow up is the equipment. So proper court shoes are a must with pickleball. We talked about heel cups can be helpful for plantar fasciitis. If you're starting off the game, a continental neutral grip is really helpful, and we'll go into details about that. The neutral grip for holding a paddle is really helpful because one way that you can get tennis elbow is from moving constant extension of your wrist like this. And so that constant extension, when you're in a neutral grip, you can handle forehand and backhand without overextending your wrist as much. The third thing that we talked about is that happens to novice pickleball players. They hold the paddle too tightly. And if you hold it too tightly, that can increase your chance of having tennis elbow at the elbow. The other thing that we've seen for pickleball players is picking a lighter racket. If you have a heavier racket, it can be significantly harder. And then the last thing is getting used to the ball being significantly lighter, and understanding that it's going to go significantly, drop a little bit lower than a tennis ball. So getting used to that and practicing for that change in ball speed and height is really, really important. This is just an example of the continental grip. So you'd put your index finger at the 2 o'clock position, as you can see here. And this allows you to have easy flexibility between forehand and backhand. So after pickleball, we're going to talk about an update to arthritis management for 2024. This was 2023 update that we just wanted to highlight for you guys. But there's, arthritis happens to many joints in the body. And if you're a weekend warrior or elite athlete, you can start developing arthritis very early on in your life. And so ways to prevent arthritis to getting worse is really important. And as you can see in this scale here, so this is an example of our grading for arthritis for the knee. We start off with normal, nice bones, and then as inflammation happens in the joint, then you can have some squaring off or little bone spurs that can happen. And then eventually, as the bones get closer together, the meniscus can tear in the middle, and the bones can get more and more close together. And that's where we look at severity of grade 3 and grade 4 arthritis. So, coming into the clinic, knowing where you are in your arthritis stage is important, where we think about different management treatments for you. But some good old prevention for this is turmeric has been shown to be helpful. We've seen that some studies recently showing 500 to 2,000 milligrams per day of turmeric, so the spice, can be helpful. It's natural and something you can try at home. Their studies aren't extremely strong for this, but they're better than some of the chondroitin sulfate studies that we've seen in the past. Second, there's been an update to the American Academy of Orthopedic Surgeons. They now support PRP, which we'll talk about, which is called platelet-rich plasma for mild to moderate knee arthritis. And then third, there's been a huge update into the importance of knee strengthening and a self-management program. And we'll go over some of the modalities that have been shown to be more effective, which include knee strengthening, glute strengthening on the side of your hip to take pressure off your knee joint. So this is the ACR arthritis guidelines, and they break things up into hand, knee, and hip that they strongly recommend and conditionally recommend and recommend against. And some of the strongest recommendations they have is for making sure that you're strengthening your muscles as much as possible. Walking is helpful. And the reason why is because arthritis causes stiffness. And so if you exercise and you walk, it lubricates the knee joints, which I think is very important. Continually having a sustainable lifestyle change of strengthening your muscles, especially above the knee, has been shown to be helpful. The single best thing that you can do for your body, and especially this time of year, is weight loss. Weight loss has been shown to really take a lot of pressure off the knees. So if you lose 5 pounds of weight, it takes off 10 to 15 pounds on your knees. And then bracing for your thumb and a knee brace can be helpful too. The things that the ACR Arthritis Foundation guidelines conditionally recommend is they recommend, and the things I want to highlight here is for hand injuries, paraffin wax. So if you go to a nail salon or hand therapy center, they usually have paraffin wax where you can warm your hands, and that warmth of your hands really helps managing the symptoms of the stiffness. Yoga has been shown to be helpful, and then patellofemoral braces. So if you have an injury to your kneecap, then a brace with a knee cutout can be helpful, which is a patellofemoral brace. And preventing pickleball injuries and other injuries, it's really important to, in addition to strengthening, incorporating balance training in your exercise routine. In fact, the American College of Sports Medicine now recommends that 1 day a week is involved with balance training, whether that's yoga or other balance exercises. As far as some of the treatments for medications, there are more selective medications like Mobic or Celebrex, which don't affect your kidneys and stomach as much, but oral NSAIDs has shown to be pretty effective. And then sometimes if it's a joint that is close to the skin, you can use a over-the-counter Voltaren gel that can be helpful. And then as we look at things not to do, and specifically when we send you the physical therapy we really believe is a sustainable way to improve you from injuring yourself, and the strength exercises are really important. And some of the passive modalities, meaning like massage, ice, can be very helpful, but a TENS unit has been strongly advised against now by the ACR guidelines. So we really don't recommend a TENS unit, which is a machine that's placed on your knee or your hip, and it causes the machine to vibrate. That hasn't been shown to be as effective anymore. So with that, I'll pass it on to, we'll move on to a regenerative medicine update. So we really focused on prevention of injuries. Then we focused on specifically pickleball, focusing on arthritis management. Now we're going to move into, if we do get injured, how can we really manage the pain, really live a sustainable lifestyle so we don't need a surgery, hopefully. And so that's where regenerative medicine has come into place. And there's been some recent updates and studies, and we'll highlight a registry that we've been collecting at Aligned Orthopedic Partners. So the two types of treatments for regenerative medicine are PRP and autologous stem cells. And the one we'll really highlight today, which has probably the most evidence, is PRP, and that's called platelet-rich plasma. And the way platelet-rich plasma works is we take someone's blood. We do this the same day as their visit. Half hour before the visit, they come in, they drink a lot of water, and then we take a small portion of their blood, and then we get the platelets, which is a buffy coat. And then we take that buffy coat, which has growth factors in the platelets, and then we inject that into a joint or tendon. And what's really important to know about the PRP is the studies have shown that there are certain body parts that work better than others, and we'll highlight a few of those today. And not all PRP is the same. You really want to have a significant amount of volume that you can take and a significant concentration of the platelets so you can have an adequate dose. It's like if you're taking ibuprofen, you wouldn't want to take a small amount of dose for that medication for it to be therapeutic. And that's where we've really learned about the PRP concentration being very important. And a lot of patients come in, they ask me how PRP works. And I usually tell them that the way it works is that arthritis causes inflammation, and PRP has growth factors, and it works in 3 different mechanisms. And also, since it's your blood, it's very safe, and you can't have an allergic reaction. And these are all the growth factors that are involved with PRP. And you can see there's numerous different growth factors that have some type of effect on your joint or tendon to help with healing. And as we look into this slide, I usually break it down to patients and the way it works in 3 categories. One is inflammation. So similar to a steroid injection, PRP blocks an area which in a pathway that blocks certain cytokines, which are messengers that cause pain. And so when you block that pain, you can have less inflammation in that area. The second thing that PRP does is it brings blood flow to the area. We know that some areas don't get good blood supply, whether it's a tendon or a joint. And so by bringing blood supply to the area, it helps with cartilage and tendon healing. And then the third thing, we know that PRP doesn't regrow cartilage. That's something that's very important to know. But we know that the third pathway can be cartilage protective, meaning it might be able to avoid unnecessary cartilage deterioration down the line. But what's really important is what you eat, what you consume really affects the concentration of the PRP. That's why we're still studying it. And this is a good study that showed that the age of a patient and their gender and their BMI all affect the amount of platelets that we can get in your body. So what are appropriate use cases for PRP? Well, we wanted to make sure that we looked at all the studies, we get very standardized so we can make sure that if we're going to provide care to our community, that we're very appropriate and understand what would be a good outcome. So a good outcome for arthritis is that someone will have at least a year of pain and function improvement. And it could be a year to several years with 1 injection. A tendon treatment is 1 injection, and it requires long-term improvement for their tendon. And they're able to get back to the activities that they enjoy. So for shoulders, we recommend it for low-grade partial tears that are small tears in the rotator cuff. And one of the most common injured tendons is the supraspinatus tendon. The second areas we recommend it to is for mild shoulder arthritis. We also recommend it for tennis elbow and golfer's elbow, mild thumb arthritis, mild hip arthritis, and that's very important to being mild knee arthritis, glute tendonitis or trochanter bursitis, Achilles tendonitis, and then plantar fasciitis. And when we're very standardized with our approach, the treatments that we have, this is some evidence of all the data we have from the past year that we've been collecting in our registry. And we're trying to be very standardized with collecting research at Ortho Bethesda and Aligned Orthopedic Partners. And you can see in this scale in our registry that the average pain improvement is about 11 points and the average function improvement is 6 points. Someone who has an amazing outcome in knee surgery usually can expect anywhere between 6 to 6.5 points of improvement in their function. So we're seeing some really strong results of very prescriptive patients. And of the 130 that were done last year, we've seen that we had 4 people who didn't do well, and that there was a 96% success rate. In the literature, 70 to 80% of people will have a good outcome, depending on the condition that's being treated. This is just an example of someone that had a good outcome.
PRP for her elbow. She's been having pain for over 2 years now. Do you mind telling the doctor about how you're doing?
Sure. So I had the PRP procedure done 8 weeks ago. And at about the 6-week mark, I really started feeling improvements. The pain decreased from the touch and movement. And now at about 8 weeks, my pain level is about a 2 periodically after physical therapy. This is the best I've felt in 2 years since we've been trying to address this elbow tear and rotator cuff. So this elbow tear, this is the best I've felt in 2 years. So I'm amazed after 8 weeks how much my pain level went from an 8 or 9 to a 2, and it's intermittent. It's not consistent anymore.
So she had a good outcome. What's really important there is that she still had a little bit of pain, so it doesn't all go away right away, and it takes 3 to 6 weeks for it to kick in. Unlike a steroid injection, which can take several days, it takes several weeks for someone to have a good outcome. But the MBA has come out with a consensus statement by some very prominent orthopedic surgeons supporting PRP for knee arthritis and patella tendonitis. And then the American Academy of Orthopedic Surgeons in the last year have provided a really good technology overview that's open to the public, so they can look at studies and see that PRP is a good treatment for mild to moderate knee arthritis. So I recommend anyone that wants to read that to go look at those articles. I'll just finish up with the regenerative medicine on, in addition to the medicine that we use for the PRP and the conditions that are clinically appropriate, the rehab program afterwards is really important. And I've published book chapters on, really making sure that we have a really good rehab program so we can provide a good package to your entire treatment for your care. And I won't go into too much detail, but there's 3 phases of healing. And so we usually protect the tissue for the first week, followed by range of motion and early strengthening in the second and through 6 weeks, followed by really advanced strengthening and return to sport by 6 weeks. And for each condition, we have very robust protocols. So if you come in, that is the standard of care what we'll provide. So next, we're going to do some surgeries for pickleball players. One of the things that we talked about was wrist injuries. And because people hold the racket so tight, sometimes they can get carpal tunnel syndrome, which is a condition where you get numbness and tingling in the first 3 fingers. And there is a treatment that we can keep pickleball players without taking too much time off from playing pickleball. And it's a carpal tunnel surgery that I do where you make a little incision in the wrist. There's no incision in the hand. And then we do these in the clinic where we can actually essentially with a balloon, what we do is we actually can use a device with a balloon and actually go in and look where we have to release the ligament. And then we can use this device and a blade to actually cut the ligament under ultrasound guidance. So very minimally invasive, people can get back to sport very quickly within a week. And it's treated for carpal tunnel syndrome. And there's been some really good, strong clinical outcomes over the past years published by the American Academy of Hand Surgery. This is one done at Jefferson University, another that recently published in the American Journal of Hand Surgery, showing long-term clinical treatment options, clinical improvement for carpal tunnel syndrome. With that, I'll pass it on to Dr. Davis, who's going to discuss surgical treatments that he'll perform.
All right, looks like can you hear me now, Mark?
Yep.
All right, perfect. Excellent. And I'll let you can actually throw those slides back up as well. So excellent talk. Obviously interesting stuff regarding the pickleball crowd and seeing some of the orthobiologic non-surgical options that are out there, and seeing that those have very predictable and favorable outcomes. So yeah, as a sports specialist, it's interesting with pickleball. We see that in looking at some of the stats that you put up earlier, Dr. Gruner, we saw that the types of injuries that we see with pickleball are a bit different than what I'll see with some of my other sports, whether it be soccer injuries or football injuries. Obviously, football, we have head injuries at a higher rate than some of the other sports. We'll see that in soccer as well, but the pickleball injuries tend to cross over some of the other specialties, and so when I did my residency in Indiana, we would cover the Indianapolis 500, and we'd have our sports guys there, but we also had our level 1 trauma guys there as well, and so some of those injuries kind of went outside of the purview of the standard sports doc, and we're seeing similar scenarios with pickleball in that a high number of the injuries sort of cross out of the sports medicine area, and we start to look at, there's 9 specialists, 9 subspecialties in orthopedics, and save for pediatrics and oncology, we'd see that the pickleball injuries really kind of involve all of the orthopedic subspecialties, even our joint replacement specialists. So it's an interesting phenomenon as we see the numbers increase. We really have to sort of approach the activities somewhat differently than we do some of our other sports, recognizing that the variety of injuries is a bit broader. But this is the idea is to say that are you injured, are you hurt? I think that a lot of the things that Dr. Gruner goes over kind of fall under the injured side of that, and then if you're hurt, you see folks like me. So if something's severely broken, but so I wanted to add some context to, or add some additional information to Dr. Gruner's excellent talk regarding some of the surgical injuries, because we do see that the rate of surgical injury is higher given the energy and the speed of the sport. So I wanted to present a couple of cases, and we'll go over some common injuries. We can go to the next slide there, Mark.
Yeah, do you see the slides, Dr. Davis?
I do see them. I don't know if I can control them though.
I'll go to the next slide. Just tell me next slide.
All right, I'll give you a wink for the next slide then.
Yep.
All right, so so just looking at the injuries, it's interesting. One of the slides that Dr. Gruner had up earlier showed the injury incidence per based on the age. And so even though we've seen this rapid increase in the number of folks who are playing pickleball, and that was across all age groups, we saw an exponential increase in the number of injuries in some of our older players. And so they're certainly disproportionately represented. And we see that 80% of those injuries occur in players that are over 60. And so when we look at that population, we have some other risk factors that can complicate things, such as osteopenia or sarcopenia, which is a loss of muscle mass. and deconditioning and what have you. So all these factors sort of increase the risk of injury in that population. And so we want to be able to appreciate that from a standpoint of preventative things, such as some of the things that Dr. Gruner went over. And then also we look at the types of injuries, as he mentioned, slips and trips and falls. And then there's this diving thing, which is a little concerning on the hard court, but that certainly has itself carries a pretty high risk. But when we look at the population, this is something that Dr. Gruner also went over in terms of the difference between the male and the female players, where the male players are mostly sprains and strains, sort of stop and go injuries, and our female players are suffering fractures at a higher rate. So as we look at preventative measures, we want to be able to appreciate those factors, because we can treat. We'll use different approaches to mitigate risk or mitigate injury, should I say? So you can go next slide there. So then when we look at injuries, obviously high injury rate, the majority of these injuries are going to be treated non-operatively with physical therapy, splinting, at times injections, whether it's an overuse injury like a rotator cuff. And then orthobiologics as well will play a major role in terms of injury recovery. And so that, the goal is to that the majority of patients we can treat non-operatively won't require a surgery. And so even though we'll present some surgery cases, we do recognize that that won't be the case for the majority of folks that become injured. All right, so then the other piece that we looked at briefly was the fact that, again, women have fractures, but it's a 9 times increased risk relative to their male counterparts. And when we look at the male players, the majority of these sprains and strain injuries are happening to the lower extremity. And so again, as we look at injury mitigation, these factors will play a role in terms of how we address those. All right, so we'll look at a couple of cases to sort of highlight some of the risk scenarios and the type of injuries that we see. The first sort of hypothetical patient who may be on a court right now as we speak is a 68-year-old right-hand dominant female who falls while backpedaling. And that was one of the things that Dr. Gruner highlighted, and I want to emphasize that as well. It's the backpedaling is a major risk. Obviously, it's a sort of a reaction to a reflex, if you will, to a ball that's above your waist or shoulder height. It does cause us to stand up higher, and so it increases our center of gravity while changing our momentum from forward to backward, and so that is generally associated with a high risk of injury. So in this scenario, the player lands on the outstretched left arm, which is a little bit of a silver lining in that it's a non-dominant arm. Likely they have the paddle in the dominant arm. And so, but experiences immediate severe left wrist pain. So in this scenario, this is a wrist fracture, most likely. We see that the fall on the outstretched left upper extremity leads to increased stress on the bone. And in this scenario, oftentimes the patients will have osteopenia or decreased bone density. So in that way, they're at a higher risk. And we'll find that when these fractures do occur, there's a high incidence of requiring a surgery. So 1 in 4 will actually require a surgical procedure. And when we look at surgeries, why do we do it? Oftentimes it's the indication is that the bone is significantly displaced, or there's extension into the joint that would compromise healing and function. When we look at some of the technologies that have helped us to treat these fractures, and one of these is the volar plating, which I've been using since I was a resident, so over 20 years, and it still works very well. These plates are specifically contoured for the wrist, and when we say volar, meaning that the plate is placed on the palm side of the bone. Historically, the plates were used on the back side of the dorsal aspect, and those plates tended to have higher risk of complications such as tendon injuries or irritation, and the risk of requiring additional surgeries was a lot higher, and the function was worse. So it's been a great addition to our playbook in terms of having the volar plates. We can certainly restore function, and patients are able to get back to their activities. whereas treating this fracture in a cast, generally we're 6 to 8 weeks in a cast, but sometimes longer, and then starting therapy. With our volar plating, patients are in a brace for 1 week, and then they start physical therapy the following week. So the downtime is much less. And then when we look at the return to play, generally it's still 3 months for folks to get back. Obviously, we have to get the bone to heal, and then the goal is to restore the strength and mobility in the injured extremity. We will find that patients will have decreased grip strength as they go back to activity. So if this is the dominant hand, obviously that will impact their ability to use the paddle. So then we may have to make some adjustments, whether it's the grip position, as Dr. Gruner mentioned, or grip size, or the weight of the paddle. So those are things that you want to consider as we try to get these folks back to their activity. All right, so let's do this second scenario is a hypothetical of 54-year-old male who pushes off to reach a drop shot, feels a pop in the left lower leg. And as I mentioned before, lower leg injuries are 7 times higher in the male patients. And sort of characteristically, when we see these patients, they feel as though they have they were hit from behind. Oftentimes they'll look behind and there's no one there. They feel like a ball hit them from behind. And it really is just the reverberation of the injury that causes that sensation. So this scenario, the patient's unable to bear weight, and they come in the office and we evaluate them. But this is a classic scenario for Achilles tendon injury, where the person feels a pop and again feels as though they were hit from behind. When we look at these injuries, we generally will treat these either surgically or non-surgically, and there's some pros and cons to either treatment, which I'll go over. But the indications are generally patient-specific. We'll have a conversation with the patient around the pros and cons regarding treating these surgically versus non-surgically. One of the major risk is, or major concerns is re-injury. And so we'll have a conversation around which treatment option is better to minimize that risk. From a technological standpoint, we've had some improvement in terms of the techniques and implants that we use, whether it's what we call the internal brace, which is a high strength suture that I'll go over in just a second, or this PARS technique, which is more of a percutaneous. The picture that we see there demonstrates a more traditional open technique, where the 2 ends of the tendon, which are separated, are then sutured together and essentially closing the gap to decrease the amount of healing that the body has to undergo. All right, so when we look at, this is a study recently that was a pretty large study, multi-center study that was published in the New England Journal of Medicine. There had been some recent reports. I will say historically, we considered the open repair to be superior to non-operative, in that we had a much lower risk of re-rupture. There had been some recent studies that had sort of disputed that concept, and that the re-rupture rates were shown to be comparable in non-operative patients who were treated with an early functional rehab. But this is a larger study, and it does show a concern regarding the non-operative treatment, and that there was a 10 times increased risk of re-rupture. In our operatively treated patients, there's a risk of complications such as wound healing issues or nerve injuries. Certainly in our diabetic patients or our smokers, those are conversations that we have, that the majority of the patients that have some of those complications related to surgery have some comorbidity or smoking that might put them at an increased risk. All right, so we look at return to play for these. Obviously, there's been a lot of talk recently. Non-pickleball guy Aaron Rodgers with his Achilles tendon rupture. Generally speaking, the majority, 2/3 to really not greater than 90% of folks are able to return to play. It's a slow recovery time, and so generally the recovery is 9 to 12 months. But we have seen the decreased risk of re-rupture with surgery. And as I said, less sort of wound complications that are associated with a non-surgical. But what we do find is that even though the risk of re-rupture is higher with non-surgical, ultimately the patients are able to get back to function equal to the surgical procedure. So we know that the folks are able to return to activity. It does take a bit longer, but they do have that increased risk of rupture, especially in the first 12 months. And then, so looking at another case, this is a 63-year-old. Now we have a left-hand dominant female. She's got a history of occasional right shoulder pain, but experiences acute worsening pain while trying to hit a ball overhead. And this is one of the topics that Dr. Gruner mentioned earlier. Hitting the ball overhead does put the shoulder at risk, especially in patients who have pre-existing shoulder disease. And so she has an acute worsening of her right shoulder pain and is unable to raise her arm up overhead and comes into the office for evaluation. So in this scenario, common scenario for rotator cuff injury, the image at the top right shows a shoulder and the rotator cuff, which is comprised of 4 tendons, and most commonly the supraspinatus, which allows us to raise our arm up overhead, is involved. And so it's not uncommon that we can have an acute on chronic injury where we may have some fraying or some wear and tear in the tendon, and then sort of like the rope finally giving way, the tendon can fail due to an acute episode. Most commonly, it's a fall on the outstretched upper extremity in an acute sense, and then more of a repetitive wear and tear in an acute on chronic scenario. When we look at the incidence of, actually, Mark, can you go to the next slide? I think this would be helpful to go to the next slide. We'll come back. But in the general population, there's 23% of the patients that we'll see that have rotator cuff pathology, and these are in asymptomatic shoulders. And we can see that that incidence does increase as we age. So in the 50 to 59 age group, it's 13%. And it goes all the way up to basically, 50-50 chance in folks that are over 80. So when we look at folks with rotator cuff tears, especially in our older patients, we have to appreciate that a lot of those patients may actually have rotator cuff tears prior to the acute episode. And so our initial goal is often to decrease their symptoms depending on their level of function. So we want to keep all of these factors in mind as we treat them, and not just use a one-size-fits-all approach. Mark, can we go back to that last slide? That'd be helpful. All right, so in terms of the indications for treatment, especially for surgical treatment, it's going to be pain, functional impairment, and then generally tear size and pattern. We do know that the rotator cuff tears can worsen over time. And so if we have a patient who's functional, who wants to get back to their activity, they have a high-grade tear or significant tear, that may worsen over time, even though we can see in asymptomatic shoulders, rotator cuff tears that we don't treat surgically. But when we have a patient who's symptomatic, who has a high level of activity, then we generally will err on the side of treating it earlier, because we do know treating smaller or less complicated tears generally has a better outcome. Now we look at treatment options or technology. Arthroscopic procedures have certainly improved our understanding, our ability to address pathology. Essentially, we get to step into the room and really evaluate the tissues in a minimally invasive fashion. Different suture anchors have also improved our ability to treat these injuries. And when I mentioned suture anchors, we can see that on the top left, that image, that's an actual implant that's used to repair. It's not too dissimilar to an anchor that you would put in drywall at home. Essentially, that goes into the bone and allows us to reattach the tendon back to the bone, and then to allow for a biological healing process. So as you can see with the picture on the top right, when the tendon tears, because it's elastic, it generally will displace and pull away from its normal attachment site. And so the anchors allow us to reduce the tendon, but also to stimulate a bit of a healing response. One of the more recent developments that really has been exciting are some of the implants or bioinductive implants, such as the one that we see on the bottom image, which is a collagen patch that can be placed on top of the tendon. And this is helpful in some of our older patients whose tendons might thin or atrophy over time. And so it's been shown that these grafts can can stimulate a healing or growth of the tendon. And we also have grafts that are more structural in scenarios where we have a tendon that's significantly thin and we want to add a structural integrity to it. So these different options, whether it's grafts or implants, have allowed us to really improve our outcomes with some of these really challenging cases, allow folks to get back to activities. So then, and when we look at rotator cuff tears in terms of return to play, everyone wants to know, hey, when can I get back? So generally it's a 6-month recovery process, sometimes even up to 12 months. I generally will tell most of my patients that have high-grade tendon injuries that they'll continue to heal for 2 seasons or 2 calendar years. So, but generally by 6 months, we're able to get most folks back to activities. So we see that about 3 out of 4 of the patients are able to return to their sport, and about 2 out of 3 are able to return to their prior injury level. And it's a fairly mixed bag when we look at the rotator cuff injuries. And so that, the severity of the injury will certainly impact the ability to get back to the sport and certainly to get back to prior injury level. All right, so next case, this one's a little bit more common. This is a 71-year-old female who has a right knee pain 1 day after playing a competitive match. And obviously these matches get pretty competitive from what I hear. And so she's got no obvious injury, but notes pain and swelling and has some difficulty walking. And she says that her knee just gives out on her at times. So she comes into the office for evaluation. And this is a common scenario for a meniscus injury. Generally, the incident may not be obvious. The meniscus doesn't have nerve endings, so oftentimes we don't feel when it's injured. It's sort of like getting a pebble in your shoes. So over time, it starts to become an irritant. So the diagram on the top right shows the knee anatomy. We have 2 menisci in the knee, one on either side, the medial and the lateral side, or the inner and the outer side. And the meniscus functions as a shock absorber in the knee. And so when it's functioning properly, it allows us to do impact activities with less pain. As we develop arthritis, as Dr. Gruner was discussing previously, we can get natural degeneration of our meniscus. And so just like with the asymptomatic shoulders with the rotator cuff tears, there's certainly a number of patients in our older patients who have asymptomatic meniscus tears. And so we want to be able to evaluate each patient specifically in terms of how the injury is impacting them. And so, but we will see that, actually we'll go back to that last slide there, Mark. We will see in the general population of 61 per 100,000 folks will have pre-existing meniscal injuries that they may not know about. So then generally when we see meniscal injuries, especially in some of our older patients, we'll generally take a fairly conservative approach initially, understanding that it's not uncommon that this may pre-exist. And so, but the indications for treating these certainly surgically can be persistent pain that hasn't responded to conservative measures, continued functional impairment, and then certain tear patterns can be a direct indication for surgical treatment, whether it's a tear at what we call the root of the meniscus, which is where the meniscus is anchored, or sometimes we'll get what are called bucket handle tears, which is the bottom left tear there, where the meniscus tears at its margin, and that can then shift into the knee and act as a sort of a block to knee motion. So there's certain tear patterns that can be direct indications. Now, from a technological standpoint, MRI has been great. It allows us to evaluate these tear patterns and to determine most appropriate treatment options. So we have a sense of what to expect, and so we can then separate patients out based on their tear pattern. Some of the other advancements have been just our implants, and so whereas before some of these procedures were being done open, nowadays we're able to do these through minimally invasive procedure approaches, and the implants that we have at our disposal are very reliable and strong, as well as low profile, so we can very meticulously repair a meniscus. Now, most times, we go to the next slide there, Mark, the majority of the tears are degenerative tears. And so the top image on the right shows the blood supply to the meniscus. And this is a classic image where there was dye injected to really highlight the fact that the blood supply only penetrates a certain percent through the meniscus. We generally divide the meniscus into 3 zones. One is the red zone, which is where we see all the blood supply. And then there's the red-white zone, which is that transition zone. And then that inner portion, the innermost portion, is what we call the white zone. And that area gets no blood supply. It really gets its oxygen just through osmosis, through the synovial fluid in the knee. And so when we get tears in these areas, then those tears generally have a very poor potential to heal. And oftentimes they present to us and they look more like crab meat than they do like cartilage. So Mark, can you hit that play there? So this is a view inside a knee, a representative sort of crab meat meniscus tear where there's no blood supply. And we kind of get an appreciation of how the meniscus can move inside the knee and back and forth. And so at times it can be asymptomatic. We used to call them a joint mouse, and they would sometimes come out of their hole and cause issues with the knee. So this is an arthroscopic view using small instruments allow us to minimally invasively access the knee to deal with the unstable meniscal fragment while protecting the lining cartilage. And now we can see that the meniscus is nice and stable. And these patients tend to heal up pretty quickly and are able to get back on their feet. Most times patients don't use crutches and they're walking within a day or so, or even the next day, and have very little pain. So this has been very helpful for patients who have, again, symptomatic meniscal tears that have not responded to conservative treatment. And then, as we mentioned, there are some patients that do require repair, and the repair patients tend to take a bit longer. Oftentimes, we have to protect their weight bearing. So, in these patients, return to play can be a bit more extended, so 4 to 6 months. The return to play numbers can be a bit varied, whether it's 70 to 100%, depending on the severity of the tear. And then a lot of the patients may have pre-exist or may not be able to return to their previous level of activity due to just continued pain or loss of function. So, but we do know is that early treatment is best. And so, so early diagnosis when the meniscus is torn, the meniscus is initially helpful, but then it becomes harmful to the knee once we have a loose, unstable fragment. So that can cause wear and tear on the lining cartilage. All right, so last case is a little less common, but I think it's an interesting one. And with the pickleball court, I think it does put and the rules that are in place. This injury, I think, is probably a bit higher, has a higher percent because of that. Those rules and the dynamics of the court. But this last one is a 61-year-old Mayo who's running toward the kitchen as it is and has to stop suddenly to avoid stepping into the kitchen. And then with that, bends forward at the waist while the knee is straight, and he feels a sharp pain in his buttock area. He's unable to continue playing, and the next morning his wife sees him getting dressed and notices that he has some bruising on the back of his thigh. So this is a classic scenario of a proximal hamstring injury. And when we're looking at the incidence of injuries, we saw that that strains and sprains were very common, and that is true. And hamstring strains are very common as well. But this is a little bit different where we have an injury to the attachment site of the hamstring at the level of the hip. And these injuries tend to be fairly debilitating, can cause pain and loss of function. And so in the classic scenario was the water skier, as you see on the bottom left, where the ski is caught in with the resistance of the water as the boat moves. And that's the classic scenario. One of my attendings in my residency, Pete Chalet, was the one that described this as a lot of the folks were at Geist Reservoir, which was north of Indianapolis. But he was the first to really show that we could treat these injuries and that the patients actually did better. Historically, this was thought to be a non-operative injury, and most patients were treated as such. And so we found that they just had a higher risk of re-injury. And so once we acknowledged that, we were able to treat this and to improve outcomes. So at this point, we would say that the indications for treatment is a 2 tendon tear. And when we look at the anatomy of the hamstring, there are 3 tendons that are inserting. And so if we have a partial tear or a 2-tendon tear that has more than 2.5 centimeters of displacement, it's shown that these patients will do better with surgical treatment. Or if we have a full tear with any degree of displacement, we'll see that these patients do better as well. Interestingly, on this, the top right image is an MRI image, which shows a tendon that's torn, the area that's highlighted. And that bright area is just fluid and swelling in the area, but it highlights the area of displacement. But if we look at the opposite side, we can see that there is some increased signal or a bright signal on that side as well. And that's not uncommon in that these tendons often are frayed, or we have some wear and tear in that area. So when they tear, it's not a normal tendon that's torn. And so oftentimes folks may have had pain in that area prior to the acute episode. So once it's repaired, they often feel better than they had even prior to the injury. All right, so just looking at real quick on this surgical treatment on the right, it shows the injury, and generally we'll use, again, the same suture anchors that we'll use for rotator cuff tears are very similar, allows us to restore the anatomy there. When we look at the return to activity, again, it's similar. It's a 5 to 6 month recovery, but we do have a high percent of these folks are able to return to their pre-injury, to return to their prior sport, and greater than 90% are returning to their prior sport, and even greater than 80% are getting back to the same level or even higher. And again, that sort of is in line with the fact that oftentimes these folks have a partial injury or some degree of tendon damage that then predates the acute episode. So, but we do know as early treatment, just as before, improves outcomes. All right, that's all I have for you, Mark.
All right, guys, that was great. I appreciate it. I know we have a lot of questions. I think there's like 39. What we're gonna do, because there's a lot of questions here in the chat, we're gonna make sure that we answer all these, and we'll provide feedback to some of these questions since we didn't have time on the call. But thank you guys for having us today.
Absolutely. Thank you guys for joining us today. It was an excellent talk.